good afternoon everyone. I am Dr. Shrujna Reddy and today we will be discussing interrupted aortic arch. Coming to the introduction, it was first described by Steidl in 1778 and it's one of the very uncommon congenital cardiovascular anomalies, and it is technically defined as lack of luminal continuity between the ascending aorta and descending aorta. The incidence is nearly 1.5%. It constitutes about 1.5% of all the congenital heart diseases, and out of these the most common form is the type B morphology. Though it has been postulated that type A morphology can be seen in increased incidence if associated with truncus arteriosus, and they have also found there is slight predominance in males. Coming to the embryology, we have the aortic arches, which usually develop by 3rd or 4th week. There are 6 pairs of aortic arches. The first and the second, as you can see in the diagrams, the first and the second disappear, and the third pair usually forms the common carotid artery and the first part of the internal carotid artery. The fourth pair on the left side between the left common carotid forms a part of the arch which is between the left common carotid and left subclavian artery, while on the right side it forms the most proximal part of the right subclavian artery. Coming to the sixth pair, it forms the pulmonary artery and the ductus arteriosus. Usually the dorsal aortas disappear between the inlet of the third and fourth arches and they form the carotid ducts. It is postulated that the embryology behind the interrupted aortic arch is probably due to the obliteration of the fourth part of the aortic arch and the dorsal aorta, as you can see in the diagram. Coming to the anatomical classification described by Celoria pattern, there are 3 types. Type B is the most common form, followed by type A and then the rarest is type C. Type A the interruption occurs distal to the left subclavian artery origin. Type B occurs between the left common carotid and the left subclavian artery origins, and type C, which is the rarest form, which occurs proximal to the left common carotid artery. Each type has been divided into further subtypes depending on the subclavian artery origin. Subtype 1 is a normal subclavian artery, type 2 is an aberrant subclavian artery, and type 3 is an isolated subclavian artery which arises from the ductus arteriosus. The anomalies of the brachiocephalic vessels are frequently associated with interrupted aortic arches. Aberrant right subclavian artery is the commonmost and most commonly occurs with type B interrupted arch, and then followed by type A. The right subclavian artery can also have a very high origin and from the right common carotid. The ductus arteriosus, the right sided persistent ductal arteriosus is also a common association which can continue either as RPA or can give origin to right subclavian artery. Rarely there is an association of right aortic arch. Ascending aorta is usually small in size and half the normal diameter and appears to be dividing into 2 branches of equal size, giving a V sign, and the pulmonary trunk is huge. The descending aorta is the usual continuation of the ductus arteriosus, and hence there is a ductal dependent circulation happening in these children. In newborn kids, there is it's often been found that the gap is of a variable width between the 2 aortic heads, and rarely there can also be a fibrous strand which connects both the ends, and it usually appears and like a very severe coarctation in between these ends. There are associated LVOT anomalies which are very common. In 30 to 50% of the patients, bicuspid aortic valve can be there. There can be valvular stenosis occasionally, and there can be subaortic stenosis also. Interrupted arch usually can be a part of HLHS, wherein there is a generalized narrowing of the LVOT and there is septal DV, conal septum posterior malalignment small aortic annulus and the aortic. There can be coexisting other cardiac anomalies. VSTs are a common association with interrupted aortic arch. In 10 to 16% of the patients, there is an association of left ventricular tract obstruction or valvular stenosis, and there are few patients wherein there is association with transposition of great arteries or DORV, truncus arteriosus or AP windows. It has been postulated a very close association with interrupted aortic arch and Dijot syndrome. According to Van Meyer, it is present in nearly 68% of the patients with interrupted aortic arch and 33% of patients with truncus arteriosus, and most typically associated with type B interrupted arch. There is complete and partial Dijot syndrome with a difference of presence or absence of CD4 lymphocyte abnormalities. Otherwise, both the patients have interrupted arch, hypocalcemia and dysmorphic facies. Commonly associated with chromosome 12q11 deletion is quite associated in 24% of these patients. The pathophysiology, there is no impact on the fetal circulation because only 10% of the blood flow is seen to be passing across the isthmus. The lower body is perfused prenatally through the ductus arteriosus, and abnormal fetal circulation is probably important in contributing the developmental delay that can be seen in some anomalies. Following the birth, the lower body of the newborn perfused as long as the ductus remains patent and the pulmonary resistance is high. As soon as the ductus closes, which usually happens in a day or two or within a week, it is one of the most common reasons for the entire pathophysiology of interrupted aortic arch. There is profound degree of ischemia in the lower body, and hence the further symptoms and the clinical features develop. If it is untreated and left, the median interval at which the death can occur is nearly 4 to 10 days. The clinical features is usually these children, these neonates present in a very critically ill state and due to severe cardiac failure. And as there is possibly, if the ductus is closing and affected lower body perfusion, there can be associated anuria, metabolic acidosis, there can be elevated liver enzymes which can be seen. Femoral pulses will be feeble, and if the ductus completely closes, they may be impalpable or quite vary in volume. Usually when the ductus closes, the flow reverses in the vessels distal to the interruption without much of the recognizable neurological symptoms. There are as such no specific cardiac murmurs. On auscultation, we can hear murmurs which are due to the associated VSTs or other cardiac anomalies. Coming to diagnostic tests, echocardiography establishes the diagnosis. It is helpful in localizing the site and the length of the discontinuity, and the narrowest dimensions, the LVOT can be visualized properly, and the diameter of the annulus and the VST can be visualized, its location can be visualized. CT angiography or MR angiography can be used. CT has a better spatial resolution and it gives a precise definition of the anatomy of the interrupted aortic arch. For very unusual cases, MR angiography, for example in aortic atresia with hyperplastic ascending aorta, there is a retrograde flow through the carotid arteries to the coronary circulation from the circular villus on a very unusual occasionally which can be seen. Coming to the management strategies, medical management, the introduction of prostaglandin even has revolutionized the management strategies, which was in 1976. Reports have shown that initially a dose of 50 to 100 nanograms per minute per kilogram body weight can be used and gradually can be increased accordingly. But some reports also say a lower dosage regimens are more helpful and are enough to maintain the ductal patency. The main aim of the medical management is to stabilize the child preoperatively and to improve the lower body perfusion and improve the renal function, reduce the acidosis and maximize the pulmonary to systemic ratio across the ductus arteriosus. For this, we should avoid a high level of inspired oxygen, avoid respiratory alkalosis, and if required to intubate the child, paralyze the child and control the ventilation, maintaining a PCO2 levels around 40 to 50 millimeters of mercury, and treating the metabolic acidosis. If required, inotropic agents can be added because myocardium usually is likely to be depressed in these cases. Coming to the surgery, the first surgical repair was attempted by Samson et al. In 1955 by direct anastomosis of the type A interrupted aortic arch. Here they did not close the VSD. Barrett Boys et al. They have repaired the type A interrupted aortic arch in 1970 using a synthetic conduit. In 1975 successfully there was repair of a type B interrupted aortic arch with direct anastomosis and as well as closure of the VSD. There are reports about single versus two stage repair. There are certain advantage of one stage repair over the staged approach because it requires lesser reoperations or reinterventions and usually avoiding pulmonary artery banding, which has been postulated in several reports having association with increasing the incidence of subaortic stenosis. Whilst there are other reports which who have not found any association between pulmonary artery banding or subaortic stenosis. Usually earlier they have also postulated that the two-stage approach should be recommended in premature neonates who are less than 1.5 kgs or if there is a evidence of any severe infection or any intracranial hemorrhage to avoid CPB and multi-organ failure, and if at all they are associated with much more complex anatomies like multiple VSDs are there, transposition of great arteries and single ventricle physiology. However, some authors recommended a primary repair protocol in patients with lower body weight also, but in these children usually post-operatively there is a they require delayed chest closure, prolonged inotropic support, prolonged ventilation, increased infection rates. Seraph et al. They have reported no statistical difference in mortality rate between single stage versus two stage repairs. Currently, single stage biventricular repair of the aortic arch obstruction and associated cardiac defects seems to be the preferred technique. The technique involves resection of the ductal tissues, extensively mobilization of the descending aorta usually till the second intercostals, and then repair by using direct anastomosis or a patch augmentation or also occasionally a conduit interposition. VSD can be closed through the pulmonary valve or right atrial approach according to the location. In patients where CPP cannot be used, left thoracotomy can be done and just repairing the arch in these patients is done. Interrupted aortic arch repair can be done by continuous perfusion or circulatory arrest. Usually ascending aorta cannulation or innominate arterial cannulation can be done with a bicaval cannulation. Additionally, another cannula can be inserted into the PA or the PDA in order to perfuse the lower body with a bicaval cannulation, and moderate hypothermia can be achieved, and after extensively dissecting the arch vessels and the DTA up to the second intercostals, direct anastomosis is performed. We have to carefully ligate the duct, excise the ductal tissue completely, and then in the same sitting the VSD also can be closed after arresting the heart. The interrupted aortic arch associated with VSDs and LVOTO, usually the decision to perform a specific procedure to address the left ventricular outflow tract obstruction at the neonatal operation is usually difficult. Presence of while diagnosing this, presence of a non-destructive VST because of the physiological parameters makes it quite unreliable. So anatomical measures are used here. The subaortic diameter is usually less than 2/3 of the annular diameter. In that case, it's considered a severe LVOTO. The systolic and the diastolic diameters in the subaortic region are normalized to the diameter of the DTA at the level of the diaphragmatic hiatus. The systolic ratios less than 6.6 and diastolic ratios less than 1 are indicated of severe subaortic stenosis, and these mandate the relief of obstruction. Jonas et al. They have actually postulated that there is no intervention unless until the subaortic stenosis is extreme, that is less than 3.5 mm in a neonate. There are other authors who have also recommended conservative approach if the LVOT diameter is greater than the weight in kgs plus 2 mm. If at all the LVOT diameter which is less than the weight of the child, then LVOT bypass procedures like Norwood may have to be performed. If there is if the LVOT diameter falls in between, there is no definite recommendation which can be made. The techniques which have been described are Yasui's procedure and DK's procedure with arch repair followed by a staged rasterly septation, or otherwise direct muscular or fibromuscular LVOT resection along with the arch and VST repair, or performing a Norwood operation with rasterly substation, or a staged procedure Norwood followed by rasterly, or a Roscono operation. Yasui's procedure, this was described by Yasui for single stage primary repair of the interrupted aortic arch with VSTs and left ventricular outflow tract obstructions. A single stage repair wherein he used a interposition graft between the ascending and the descending aorta, and he performed DK surgery, anastomosis, and tunneled the VST to the pulmonary valve and performed a rasterly, placing a conduit between RV and PA. There can be other associated anomalies as we have already discussed. If at all there is transposition great arteries, arterials with surgery with the VST closure and arch repair is to be done. And if at all truncus arteriosus, repair of the truncus arteriosus depending on its type, and and arch repair needs to be done. Coming to single ventricle physiology and aortic atheresias, in these there is increased pulmonary blood flow. So the initial palliation would be doing a PA band and an arch repair. The strategy usually maintains an acceptable anatomy and hemodynamics for later Glenn, doing a bidirectional Glenn and Fontaine procedure. But there have been disadvantages also postulated due to an initial PA band distorting the PA confluence or the branch arteries, making it difficult to go ahead with future Glenn or Fontaine procedures. Also, a Norwood procedure is an alternative option wherein obstruction at every level is relieved and is along with a source of pulmonary blood flow. Arch obstruction and ascending aorta less than 4 mm in diameter, the arch can be repaired by DK's type of repair. Results of surgery, earlier reports have reported a mortality of 20 to 80%. Recent studies have shown a mortality rate of 10%. The most common modes of death are cardiac failure or very late reoperation, which is due to recurrence of arch stenosis or left ventricular outflow tract obstructions. What the incremental factors which lead to death is a low birth weight or a poor preoperative condition, other complex anatomies associated with interrupted aortic arch, and even the level of interruption. It has been seen that the type C, which is rarest, has the highest mortality associated. What the causes for late reoperations? There can be recurrent arch obstructions, LVOT obstructions, there can be residual VSTs or left bronchial compression. Diaphragmatic palsy or complete heart block have also been seen. The immediate complications are usually bleeding, due to extensive dissection and the arch repair which is done, which needs to be tackled accordingly. And there is also damage to the phrenic nerve or the recurrent laryngeal nerve, which have to be very careful in preserving them while performing the surgery. Aortic arch restenosis. The prevalence of aortic arch obstruction gradient of more than 30 millimeters of mercury is usually suggestive of a restenosis, and Fulton et al. Have shown a prevalence of around 20 to 27%, while there are other reports who have shown a lesser prevalence of restenosis. The factors which usually increase the risk is inadequate excision of the ductal tissues, if there is more complex anatomy or a PTFE material has been used, or there has no been an good dissection leading to a little tension and not having a tension free anastomosis. Type B has been having increased prevalence because possibly due to again inadequate mobilization. There have been therapeutic options described as balloon angioplasties, the method of choice in recurrent aortic arch stenosis. And there have been reports of recurrence and repeated procedures requiring in these patients. There are different surgical methods which can be used as resection of the stenotic segment and end-to-end anastomosis, or construction of an extra anatomic bypass and subclavian or carotid turn down procedure can be performed, or augmenting the stenotic area with a patch. Left bronchial compression, what is the causes? If at all there is an inadequate mobilization of the aorta and constructing a direct anastomosis, can have a shortening and pulling down of the aorta on the left main bronchus, which can be possibly one of the reasons for left bronchial compression. Associated other anomalies with residual heart lesions can leading to cardiomegaly or LA enlargement or pulmonary artery dilatation can lead to left bronchial compression. These patients are usually ventilatory dependent. They can have refractory left lower collapse. Coming to diagnosis, it's by bronchoscopy or MRI can be performed in these patients. Reinterventions in these patients can be aortopexy or placing of an aortic interposition graft to release the tension. Recurrent LVOTO, significant gradient is the peak gradient of around 25 millimeters of mercury, and a prevalence earlier have been shown around 70 to 67%. In several reports, it has been reported quite low. The preoperative echocardiographic parameters are usually helpful in predicting recurrent LVOTO in future. The cross-sectional subaortic area, single ventricular, type B morphology, or presence of an aberrant subclavian artery. Salim and et al. Have showed on echocardiographic measurements that the absolute diameter of the aortic valve annulus is less than 0.5 millimeters and a Z-score less than 5 and can be predicted for development of the left ventricular outflow tract obstruction after the arch repair. Jiva et al. Have also shown that the effective cross-sectional area of the LVOT, if it is less than 0.7 millimeters per meter square, then you can predict future LVOTO. The persistence of any unresected conal muscle can result in turbulent flow, leading to progressive hypertrophy and displacement of the septum, and hence causing LVOT obstruction. It is also postulated that one complete one-stage surgery can reduce the incidence of late left ventricular outflow tract obstructions. And hence recommended is myomectomy of the conal septum from the RA or RV approach, and placing of a patch for VST on the left side of the conal septum to prevent a recurrent LVOT obstruction. Coming to the management strategies, balloon dilatation has been shown to be quite an effective method, and if it is a very severe stenosis, there may be additional interventional procedures like placing a stent may be required. Surgery, the surgical strategies include the resection of the posterior deviated conal septum. If at all it's an aortic valvular stenosis, valvotomy can be performed. If it's a tunnel subaortic stenosis, modified cono procedure can be performed. If at all it's an annular hypoplasia plus subaortic tunnel stenosis, Roscoe procedure can be performed. The pulmonary artery re-interventions, these are less chances of occurrence. If at all it is these re-interventions aim to relieve the pulmonary artery stenosis. Balloon dilatation with or without stent placement and surgically a patch arterioplasty is recommended. These patients can have repeated percutaneous procedures, or for relieving further obstruction, bilateral pulmonary artery patch arterioplasty can be done surgically. Coming to the residual heart lesions, there can be residual VSDs which may require reoperation. Small VSDs usually close spontaneously. Valvular aortic stenosis can develop in patients with bicuspid aortic valve and patients who have very narrow ascending aorta or subaortic region. There can be a degree of aortic regurgitation in patients who have an associated truncal valve repair along with the arch repair. Following the correction of truncus arteriosus with interrupted arch, there can also be an right pulmonary artery stenosis, and primary repair of the interrupted aortic arch combined with an arterial switch operation for TGO can predispose for development of other valvular or subvalvular pulmonary stenosis. Thank you.